Good afternoon, everyone. Hope you can hear me from the Akasol. Today, I'd like to share my PhD studies with you, identifying the binding site of cystic fibrosis drugs. The genetic disease, cystic fibrosis, is caused by mutations in cystic fibrosis transmembrane conducting methods, CSE. CFTR was a gated pathway of ion channels or chloride ions across cell membranes,
which are shown here in green. In cystic fibrosis, CFTR is missing, preventing its normal function in affected organs, such as the lungs. The treatment of cystic fibrosis has been transformed by CFTR-targeted therapies. These therapies benefit people with cystic fibrosis and common mutations. However, there are very many rare mutations which cause cystic fibrosis. My project aims to use the AI molecular and modeling tools to identify the binding site of new CFTR targeting therapies to benefit people with cystic fibrosis and rare mutations. In my project, I used NinaDoc, a molecular docking program with integrated convolutional neural network scores to evaluate drug poses. This forms the foundation of my protein-drug interaction models to identify the binding site of vanzacaftor, the newest CFTR-targeted drug. Further analysis were also undertaken, including free energy calculation, which helps to predict the drug binding affinities. This allowed me to identify some key residues involved in the interaction of vanzacaftor and CFTR. Being able to see where the drug binds can inform us about how it works in the body and allow us to improve the drug structures in the future designs. Thus, this provides the hypothesis about the vanzacaftor binding site, which I can test experimentally in the lab. Thus, these studies guide the development of CFTR-targeted therapies for people with cystic fibrosis and rare mutations. Thank you for listening.
Good afternoon, everyone. Thank you for the invite. My name is Diego Rodriguez. I'm also working at the University of Bristol and in the School of Life Sciences. I work with trees, I work in forests, so today I'm going to show you the results I got for my first data chapter, where we found a limited prediction at tree level resilience to drought across 6 European forests. To start, I would like to start talking about global change, which is making climate extremes more frequent, longer lasting, and severe. So that is causing lots of tree mortality and forest dieback worldwide. So to combat this, we need to better understand what are the drivers and mechanisms that makes them more or less resilient to these extremes, such as droughts. So I got 2 research questions. The first one is to try to understand what are the primary intrinsic and extrinsic drivers of tree resilience to drought. By intrinsic, I mean that characteristics inherent to the tree itself, such as their height, wood density, and diameter. And by extrinsic, I mean by the surrounding influences, such as species richness and climate. So the second one is to understand whether this drought resiliency depended on the provenance or forest type where trees are growing. This research was conducted using a 3-ring data set, which was collected across 6 different forest types of Europe that you can see here, which encompasses the whole bioclimatic gradient of Europe, starting from Mediterranean forests in Spain up to boreal forests in Finland, so that we can evaluate the effect of both provenance and forest type. So for my results, we found that the main driver was the intrinsic driver was the growth conditions prior to drought, such as pre-drought growth that influence on resistance negatively and also on resilience, but did not affect recovery because when conditions return to normal, trees start to grow faster again. When there is water, again, trees recover faster. And we also found that a secondary effect of drought intensity, where the stronger the intensity of the drought, the more I resist to this perturbation. But that didn't have a non-zero effect size on recovery and resilience. And the third one, which was interesting for me, because we could find a positive effect of their crown, which is a measurement, it's like an umbrella, which enables them to create a microclimate. The name is life crown ratio, which is the relationship of the ratio of height with respect to crown depth. So that works like an umbrella during heat waves or strong drought episodes. And then we also found that this resiliency didn't depend on the species identity, but rather on the country of origin and forest type where trees were growing. So the topographic conditions, as well as the climatic conditions, specific climatic conditions where trees grow, affect more on the resilience to these extremes. So here I have some arrows because I gave another presentation, but I didn't remove them. And then we have just here to give you a clear example of the effect of forest type. For example, for this common tree species, which the name is Scots pine, it had a negative resistance in Spain, but when growing in Poland and Finland, show a positive resistance, where we can clearly see the effect of forest type. And the same, in general, we found that trees growing in Poland were the least resistant to drought, with low recovery and resilience, and trees growing in Romania had the greatest resilience to drought, probably because they grow in a mountain forest. So it's been shown that trees that grow in steeper slopes, they have a higher resilience than trees that grow in flat terrains. So the main conclusions are that we found some few important drivers that enable trees to be more or less resilient to drought. The second one, as I mentioned, that drought resiliency didn't depend on the species, but rather on the place where they were growing. In general, we found a limited predictability in tree responses to drought, as our models only explained the 15% of the total variance. Thank you very much.
Hello, my name is Cecina, and I'm talking today about how we can make climate decisions under great uncertainty. And our goal here is to be able to make climate change adaptation decisions that are robust to a wide range of uncertainty. And I'm going to be looking at all of this through an idealized example of heat stress on outdoor workers in the UK. And in this kind of toy example, we're imagining that we have 3 possible adaptations that we're trying to choose between. And so in my research, I use a decision-making framework called Bayesian decision analysis. I won't go into all the stats, but basically this framework selects the decision that has the highest expected utility given what we know about climate risk. And as you can probably tell from the title of the talk, we're very uncertain about the climate risk. So there are a lot of factors that go into that, how hot it will get, how many people will be exposed, and all of those we're not precisely sure kind of what level of risk we'll reach. But that's not the only factor that goes into our decision. We also have information about each of our decision options. So we need to know things like how much they're going to cost to implement, how effective they are, and all of those things are also uncertain. So if both components going into our decision are uncertain, how robust of a decision can we actually make? To start answering that question, I look a little bit at how uncertainty in our climate risk compares to uncertainty in the ultimate decision. And so the purple map on the left here shows how uncertain we are in the degree of climate risk. So if you look around London, where it's super purple, we're very uncertain about the degree of risk we're going to reach. But if we then look at the decision we're going to make in that region, we see that only one of our 3 decision options is optimal, despite the huge variation in climate risk we might experience. When we consider uncertainty in both the risk and decision inputs, however, we see that our decision is a lot more uncertain. So it's important not just to consider that uncertainty in climate risk, but also important to consider that we might be uncertain in those decision-related attributes. So now that we know that our decision is very uncertain, we need to know kind of what is most driving that uncertainty in order to help decision makers prioritize data collection. I've spared you looking at all the different inputs that go into the decision, but I've just selected a set of representative risk-related inputs, like the warming level, and decision-related inputs, like some costs. And what we can see is that the decision is actually often more sensitive to these decision-related inputs than it is to the risk. And we see a lot of regional sensitivity. So it's important for decision makers to consider sensitivity on a local basis. Upshot of this work is that it's important to actually do these kind of analyses to understand how to make robust adaptation decisions.
Hi, my name is Matthew Powell, and I don't have any slides because I didn't want to just show loads of graphs and my data diagrams. So this is my talk on configuring role-based stance detection using open weight and closed weight LLMs with the semi-val topic of climate change is real as an example. So I am a PhD student at the Cardiff University Computer Science, and stance detection is the process of using a natural language model to assign a topic, an opinion towards a piece of topic, the opinion of a text to a piece of topic, either favour, against, or none. And for example, if the topic is climate change, then the piece of text is either favour, against, or is irrelevant, no opinion to that topic. The main difficulties, especially with climate change, as older models struggled with it, is the lack of knowledge and the struggle to get a lot of the colloquialisms and information out of the limited character set as the data set is, all based on tweets from 2016. So this is based on a prior paper where they used 6 LLM ChatGPT agents to, 3 of them were used to get out linguistic, social media features, and an expert opinion. So for climate change, the expert opinion is the LLM is assigned the role of a climate scientist to give that climate knowledge. These three analyses are then given to 2 debating agents, which debate if the stance is in favour or the stance is against, and then a final judgment agent takes those 6 arguments, 3 from each agent, and its own judgment of its reading of the text. So the problems with this method were that it used ChatGPT, which is closed weight and expensive, especially the more modern you go up, especially as it is private, so it does cost money as well as time, and the security restraints that leads of it going into the cloud, as well as the expense of using 6 agents. So my method is to see the effect of each of these 6 agents and try to reduce the cost, as well as baseline. So a chain of thought baseline, which is just asking the stance and to explain its thoughts, which should, again, give it some reasoning, as well as just the baseline prompt from the LLM. And to address the lack of open weight model, Llama 3 is also used, as well as ChatGPT 3.5. The debating stage is always used, so those 3 further ones, the favour, against, debating, and then the judge, and then the 3 LLM agents, the 3 and text analysis stages as separate models. So a debating agent, the social media agent, and the debating agent, the linguistic and the expert, the political expert, and then the configuration of the 2 of them. So social media, the social media and the expert, the social media and the linguist, and the expert and the linguist. The results show that chain of thought for ChatGPT shows that reasoning works. So chain of thought works very well. It gets 0.58 on ChatGPT and 0.62 overall. Across all 6 data sets, and Llama gets 0.67 with the debating stage, because the ChatGPT doesn't the chain of thought doesn't work very well. And but however, the debating stage is the best for the cost, but the linguistic and the political agent work the best overall, especially for climate change due to the imbalanced data set. With Llama, it gets 0.82, which is very surprising and higher than most papers. So in the future, we will move to a more up-to-date data set, as this is a data set from 2016, and hopefully move to multilingual, because again, the data set is in English, and see how changing the language of prompts affects results. Thank you.
I'm going to talk to you about COVID-19 today. I haven't had a chance to present this study. We wrapped it up in 2023, but I've been on a placement for the last year, so it's the first time to talk about it. So this is Greater Manchester. It is kind of one of the least green cities in the UK. So the paper's available online if you want to have a look at the details. So greenspace has lots of mechanisms by which it can improve health. At the time of this study, there were only ecological studies that were looking at green space and COVID-19 incidence and mixed results with COVID-19 severity, and only a single cohort study looking at green space exposure and predicted COVID-19 illness, and they found significant negative associations. So I wanted to conduct the first cohort study using everyone's health records in Greater Manchester and link that with their green space exposure. And I encountered I used a number of green space metrics. So availability is the total amount of green space, accessibility is the distance to your closest green space, and visibility as well. I used a number of covariates, which I thought were relevant based on the literature. I also included more covariates in sensitivity analyses. I looked at effect modifications, the difference of these associations between groups. And the main results overwhelmingly show that there's very significant negative associations with green space availability and COVID-19 severity, both hospitalization at the top and mortality at the bottom. When we look at effect modification with deprivation, we find that the most deprived groups have the strongest negative associations. So the most protective effects in the most deprived groups. So these groups often have access to green space, but the quality and the quantity is often a lot kind of lower than the least deprived groups. And you can see here, there's a kind of quote that 1 in 8 households in Great Britain had no access to a private or shared garden during the first lockdown. These are some pictures of Greater Manchester. This is a garden in a very kind of a least deprived area. And down there, this is Ancoats. So this is some public space in a quite a deprived area, but it's kind of used to be a deprived area. This is a study from Labib et al., which in Greater Manchester, which shows exactly that. So accessibility is actually highest in the most deprived, but availability and visibility are lowest in the most deprived. And again, this is Ancoats Green at the top and Victoria Park in Greater Manchester. Obviously, there's big differences in quality here and the protection they provide. So the principal findings are, we comprehensively show that residential green space reduced the risk of COVID-19 hospitalisation and mortality in Greater Manchester. More deprived groups received the greatest benefits. Reduction of air pollution is likely to be a key mechanism, though it's not the sole factor. And alternative green space metrics affected the strength and direction of associations. The choice of covariate for deprivation also impacted our results. So that's everything. Thank you.
Hi, I'm Rhiannon, and I'm going to talk to you a little bit about my project I've been working on. So I've created an empathy-driven visualization framework for dementia care. Dementia represents a major global healthcare challenge with significantly poorer health outcomes for dementia patients. A key issue is the connections and the difficulty healthcare providers face in forming effective, empathetic relationships with their patients. They see so many on a regular basis. Communication barriers can lead to patients being perceived as challenging, which in turn reduces empathy and compromises their quality of care. This is Carol. This is a lady that I met and her husband Bill. So she suffers with dementia, and she told me about her personal experience and how she felt nurses were unempathetic towards her, and possibly because she wasn't diagnosed at the time, but diagnosis can take a long time. She told me that they were a bit unempathetic, but this does exist already. So this is a This Is Me document. However, it has its obvious flaws. It's paper-based. One thing I learned talking to nurses is they don't have loads of time to sit and fill out more paperwork. And Carol also explained by the time you're 80, 90 years old, your medical paperwork can be very, very large, and they easily get lost. So effectively, I wanted to make a digital version. So how can visualization encourage empathy? I wanted to work with already established principles. So this is CARE principles, the VIPS framework, mixed with empathy mapping. These are established principles that are already used widely in hospitals and care homes. And I want to mix it with my mixed method approach of these 3 design pillars. This is to try and increase that empathetic relationship through design. So this is the framework that I came up with. I didn't want to just go ahead and make an app. It's such a vulnerable age group that I wanted to really make sure that I got the framework right, that I made the app correctly. So a massive part of the framework was to immerse yourself. So fully immerse yourself in the community. As researchers, we can't just go and interview a nurse and think that we know the problem. I suggest you fully immerse yourself into the project. Talk to dementia patients, go to care homes, go to coffee mornings, go on a dementia bus, really immerse yourself in that community so you have a real understanding of what the issue is. Humanise data. Data is often very factual, it's limited, it's quite difficult to get that sense of who a person is from reading medical documents. So I suggest humanise it, just small things like using first-person narrative. I have these triggers. I don't like certain bright lights. They really upset me. Even just having a little page about their life. You know, I'm Winnie. I was a school teacher for 40 years. I have a family. These little touches can really promote that empathetic relationship. And the goal was to do it in sort of under 2 minutes because, again, nurses and doctors don't have loads of time to sit and read. So the goal was to get something simple but effective. Really evoke, use colour, shape and symbolism, and empower the patient and also empower the healthcare professionals and implement and reflect and keep going through those processes. This was a prototype that I came up with to evaluate the framework and really understand whether this framework could be effective. It was really well received, and the goal is to fully develop this into an app in the future. I used 2 events to evaluate, so both events had nurses, doctors and dementia patients with capacity to fill out the paperwork. So I asked them to sort of test out this app in under 2 minutes, and a lot of them said, yeah, I definitely feel like I know this person a bit better just from spending 2 minutes looking at this app. So these were some of the results. So really positive, 97% efficient, effective, supportive, practical. But beyond the sort of quantitative results, the qualitative results were really important as well. So I learned from just talking and the feedback that people told me. For example, a nurse, I was going to have a hospital bracelet with a QR code that they scan because I'm designing for an end user that's not going to interact with this product. So it's not designed for the dementia patient, it's for the healthcare professionals. And she told me, I had a red bracelet, and she said, I'd associate that with allergies. I'd recommend a purple bracelet. Just things like this I wouldn't have learned had I not fully immersed myself and really got involved in the community. And then I used thematic analysis and AI to really evaluate the results and understand what people were saying. And yeah, thank you for listening.
Hello, I'm Catherine. I'm a first-year PhD student at the medical school, so a bit of a caveat to start off with. I haven't done any of this yet. I'm still in my teaching year, so these are kind of my PhD plans for when I start my main project next year. So my project is entitled Statistical Shape Modelling and Machine Learning to Understand Pregnancy-Induced Cardiovascular Remodelling. The kind of background of my project sits at the intersection between 2 research priorities that were identified by the UK Congenital Heart Disease Priority Setting Partnership, and this is essentially a partnership that brought clinicians, patients and carers all into one room to discuss what their topics of interest were to kind of drive the next stage of congenital heart disease research forward. And one of those was the risks associated with pregnancy. And the one that we want to focus on is structural remodeling. And normally this is fine, this is adaptive, it helps the woman manage increased cardiovascular load. But in the presence of congenital heart disease and other heart malformations, it can be associated with adverse outcomes such as preeclampsia, which can be fatal. And therefore understanding how we manage this structural remodeling is essential for women's health. And we want to address this by addressing the second research priority that was identified by the partnership, which is how can technology be used to improve outcomes for people with congenital heart disease. And we want to do this through a fusion of statistical shape modeling and machine learning. So for those who aren't familiar with statistical shape modeling, it allows you to analyze medical images to identify morphological biomarkers of disease. And what we can do is that we can feed those vectors into machine learning algorithms to kind of work as a patient management diagnostic tool. And the feasibility of this was already established by some of my colleagues, where they were able to train a hierarchical clustering model to cluster individuals based on what valve replacement procedure they've received as a kind of risk management prognosis tool. And we kind of want to adapt this further to apply it to women's health and structural remodeling. So just a quick overview of my experimental design. I want to start off by firstly modeling the pregnant heart. This hasn't been done yet. And to define these changes, how they change over time, because it is variable across the course of pregnancy, and how they reverse after pregnancy. And also identify differences between adaptive and maladaptive remodeling. And then we can use this to train machine learning models to predict changes over time, but also identify individuals that are at risk that may have kind of been missed through more traditional monitoring methods. And finally, it's important that these models are subject to human direction throughout the whole process. So then we're going to bring these models back to clinicians and patients to assess kind of their clinical applicability. And that will also allow us to identify additional factors that we can feed into these algorithms more. And then there is a little bit of methodological development I want to do. Firstly, considering the dynamics of the heart, but more importantly, 3D structure prediction, because these 3D structures are the most important for kind of shape modeling. But in the clinic, we use 2D images. So we kind of want to bridge that gap between analytical power and clinical applicability to kind of make sure we've got the most powerful model we can. So that's kind of my overview of my PhD that I haven't done yet. Thank you to the British Heart Foundation and my supervisor, Giovanni Biglino, for supporting me so far. Thank you.
So AI-guided ultrasound diagnosing deep vein thrombosis. My name is Kerstin Nothnagel. I'm a second-year PhD student at the University of Bristol here, and I explore the acceptability and accuracy of AI-guided ultrasound. I have a second project with the Alan Turing Institute, where I explore how global AI policies can prevent widening the healthcare gap between the global north and the global south. The key question of my talk is, AI for all or just for some? I will start my talk with a brief example for AI technology in healthcare, well, actually my PhD project. So you're probably asking yourself, what is deep vein thrombosis? Well, it's a clot that usually occurs in the deep veins of the leg. Problem is that part of the clot can break off and travel with the bloodstream to the lungs, causing there a potentially fatal pulmonary embolism. Well, we live in an aging society, and the prevalence of DVT significantly increases with age. Well, gold standard tool for diagnosis is ultrasound. Ultrasound machines require specialist skills to be operated. These specialists usually work in hospitals. So too centralized, too specialized. Can AI-guided ultrasounds change the game? Well, today we have handheld ultrasound probe. I brought one. It's a Clarius L7. Pretty cool, right? Portable, more affordable, and doesn't require hospital settings. Sorry, I need to take this. Well, so does this mean patients don't need to travel to a hospital anymore? Not quite. We still need specialists to perform the scan and to interpret the images. So that's how AI comes in. So this AI app can guide non-specialists like GPs or nurses through a DVT scan of the leg, and it even flags the presence of disease. The ultrasound images can then be uploaded to a cloud dashboard, so specialists from remote can provide a diagnosis. That would enable DVT diagnostic at the GP surgery or even at patients' homes. So AI is reshaping healthcare from faster diagnostics to smoother workflows and increased accuracy. But what's about regions without or lacking infrastructure, like parts of the global south? AI can't revolutionize healthcare if entire populations are excluded. So my Alan Turing Institute project aims to develop policy recommendations to ensure AI tools are adaptable and inclusive. This could include government incentives for technology that doesn't require constant power or Wi-Fi, that works where it's most needed. So AI for all or just for some?
We want to have a brief time for question and answering. Before I start, I just want to take my hats off to all of you. 3 minutes is an astonishingly short amount of time to have to present what for some of you is already several years worth of research, and in other cases you're just starting that research journey. So huge respect to all of you for being able to do that. They were great talks, you were really clear, thank you very much. I'm going to open it out for questions. Sorry, just before I go, I should call out Matthew. I think anybody who is willing and able to come to a data science conference and do a talk without showing any graphs or data, I applaud you, sir. That was bold, it was brave, and it was really good. Thank you. Before I open up to questions, it's quite difficult for me to find a sort of question that would unify all the things you're doing, because you're doing such a wide range of really interesting work. So I'm going to default back to something which is a bit naive, but I'd just like each one of you to give a kind of short answer about how important do you see the evolution of AI, machine learning, new data techniques to actually resolving the questions that you're trying to answer. And now, to answer this, I'm afraid I was going to use a climbing analogy, but then most people don't rock climb, so they have no idea what I'm talking about. So I'm going to use a football analogy instead, in light of the upcoming Women's Euros. So do you see data science AI for your work, for your project, being game-changing, forward, taking us to a new place? Or is it's really good, it's driving the middle of what I do, it's not the only game in town? Or is it actually, it is just a really good, solid underpinning of what I'm trying to do? Now, there's no right answer of any of those. I'm just intrigued to understand how you see AI and data science is helping out. So, Rhiannon, can I start with you? And if you forget the options, I'll tell you again.
I think it could be a really useful tool, helpful. I like to use it as a guide and give recommendations. I do think we need more ethics behind it, maybe, especially when you're working in vulnerable age groups. But I think for predictive analysis and pattern recognition, I think it's really important underpinning part of my research.
Brilliant. Kerstin.
Well, I actually used the word game changer in my slides. So yes, I think I touched on 2 areas. So I think I usually work in A&E, so in healthcare, it's a game changer. We have an aging population, means more health problems. We have less people in the workforce. That means we have to find somewhere an equilibrium. And using AI technology is the closest what we can see. And we have already lots of implementations in healthcare popping up everywhere. So I think it makes already a significantly a difference, especially here in the UK. I'm not English, but in the UK, obviously the NHS is struggling quite a lot with finances. That's another thing coming in. And yeah.
Thanks. Cecina?
Yeah, thank you. I think it's probably debatable whether I actually do AI or not, but
that's fine.
When thinking about kind of the climate change modeling space and climate change decision-making specifically, I think it's a crucial tool given the quantity of data and the disparate types of data that you're trying to pull together to make a decision. But what I will say is a lot of AI can be kind of a black box method, and when you're actually trying to interface with decision makers, policy makers, people are very unlikely to take the word of the computer for granted, so we need to make sure that we're using models and techniques that are explainable, and we're going to be able to convey that information to users.
Great. Diego, please.
Yes, thank you. I also think that it's a very useful tool because I do remember back in the days when I did my master's in China, I struggled a lot with my R coding. It was taking me a while to come out from a code to get my results. And now with the tools we got, like it's easier. You don't spend that much time, just a couple of days. And then, for example, ChatGPT can give you your code or help you, guide you to get your results faster. So I think it's very useful in research as well, but not to rely 100%. But it's good, in my view.
Great.
Hi, I don't really use it in my research, but I'm excited to kind of see how it integrates with exposure modeling, because I see real limitations in how we do that. So yeah, I'm excited for the next steps.
Thank you. Zhujun?
Thank you. Yeah, I think AI is playing a really big part in my project. So given cystic fibrosis having such a big number of the mutations, and it's very hard to give one therapy for all of the patients. So I think using AI, it helps us to speed up the procedure of generating those, well, like finding the key residues that can be important for the drug development. And not only for cystic fibrosis, but also for other diseases. I think it's really playing a big part. Thank you.
Great.
Yeah, I agree. I mean, in terms of like medical images, it's definitely a game changer, and for personalized medicine as well. However, I think I kind of touched on it in my talk. We need to make sure that these models work alongside, in my case, like clinicians, and are actually interpretable in a way that makes a difference, rather than us sort of just shoving a bunch of data that, yes, it makes the model more predictive, but it's not actually useful to, in my case, the clinicians. So it's just making sure there's a kind of, they can be translated back to the space that they were kind of created in the first place.
Excellent. Finally, Matthew.
So for me, it's already been a game changer. I've been in natural language processing during the rise of ChatGPT and all those. So like in what I'm doing, if you go back to 2021, 2022, it's struggling to get 50% accuracy, a 50% F average, and now it's 70, 80%. So you can just already sense that shift. But in a way, it's kind of reversed it from making everything bigger and bigger to trying to optimize it and making it more explainable and trying to bring that trust back into it. Because if you just give it to someone, oh yeah, I can do all this, you just chuck it in it, but people won't use it. People need to trust the system, and trust is becoming a major part, I think, trust-based AI systems.
Great, thank you, all of you. I mean, really good reflections then. I think from so many of you, one of the things I'm really struck by is that comment about actually people have got to believe this, they've got to trust it, you've got to understand it. So we're never going to move away from that human data interaction. And as a former civil servant, I agree with you. Most policymakers won't just accept what a computer will tell you, I can assure you. So there's lots of really good stuff you've all talked about. Thank you once again, and really well done for being able to summarize so much stuff in 3 minutes. Thank you.